Good morning, everybody. Welcome you back to the SIT program of AIOC. Wonderful day yesterday. We had a good time. And I think we'll start our session, ACOIN session. And the theme, as you know, it's a paradigms of ocular trauma and day-to-day community ophthalmic practice. And I have my convener, Shatanshu Mathur, he will be joining us. Chairperson, Dr. B.N. Gupta is with me. And Dr. Lakesh Madaria, Dr. Sharad Das, Dr. Muhammad Yasin, Dr. Lalit Nepalia, myself I am here, Abad Dubey. And moderators we have Amarnath De, Shekhar Sarkar. Dr. Shekhar Sarkar, please come and join with us.
Please come here.
Please join with us. And Dr. Indraman Rastogi. And we'll wait for another 2 minutes, then we'll start with Dr. Asim Seal, he is the opening batsman. So after that, I think Dr. Ruma Das, Dr. Parikit Gogte, Dr. Sunil Kumar, Dr. Soni Sinha, Dr. Jayasri Dora, Dr. Pradeep Mahanta, Dr. Subhadra Jalali Madam is there, Dr. Mehul Shah, Dr. Tariq Qureshi, and 3 minutes presentation by Dr. Manpreet Kaur, Bileshwar Samant, Sonam Verma, Dr. Shivangi Singh, Dr. Abhishek Omkar, Dr. Purba Srivastava, Dr. Pratik Nishant is there, Dr. Anujit Paul, and of course concluding remarks by Dr. Parag Mukherjee and Dr. Sapan Samanta. And there's a keynote address, an overview of ocular trauma and Indian subcontinent, Dr. Chandana Chakravarti. So whenever she comes, she will give the keynote address. And I think we will start with Dr. Asim Seal. There are two more speakers are there already.
I think we will do one thing because
it's over to Dr. B.N. Gupta.
Yeah, actually, all the speakers and different faculties have not arrived. So we will start the session and we will take up the speakers, whoever is present here. So let us start with Dr. Asim Seal. Dr. Asim Seal, as you know, is a high volume cataract surgeon. He is working in a very big charitable hospital at Chaitanyapur, and he is a well-known figure, very much interested in community ophthalmology. So, Dr. Asim Seal, please.
So, I am waiting for the presentation. Good morning, everybody.
Please come. Achha. वो दे रहे
अभिजीत पॉल ना जो आ रहा है उसको ये करते जाते हैं अनुजीत पॉल.
So, my responsibility is introducing the session. So, ocular trauma in India has various dimensions. So, what are the common issues in India? Etiology and severity varies, and it might not be easy to manage with limited resources in secondary level, primary, secondary level. And there is lack of availability of proper facility, including the pediatric anesthesia, because children are most prone to have trauma. And sometimes infection often complicates the case. So, managing that is also a big issue. And many times in our country, people present with trauma very late. So that becomes a big issue. I am going to share some little experience about that. And trauma needs proper counseling, and often the people who are dealing with it, they are not trained enough to counsel the patients properly. And what follows that, if the counseling and medical legal record keeping is not properly done, medical legal issues crop up, and I have suffered in my life. So trauma is really a very serious issue, and my following speakers will discuss it in different way. And I am just showing two examples. This one I reported in Community Eye Health Journal in 2000, and rice grain was found growing inside the eye of this child. So this child came with only watering from the eye. We opened the eye, could not find anything, gave antibiotic, And after a few days, the child came back with the swollen eye. Then we everted the lid and found that rice grain was growing inside the eye. So this one was first reported in Journal of Community Eye Health in 2000. Subsequently, I have experienced 2 more cases. So 3 cases I have experienced. And this is another case. It's a different case. You can see a tumor removed with smooth capsule from the anterior orbit. And if I show you, so this tumor was removed by me, and I thought it was a case of dermoid, but out of interest, when I wanted to see what is there inside, I was expecting teeth or hair. One piece of bamboo came out, and the mother couldn't remember when actually it happened, and it was more than 10 years old. Some piece of bamboo went inside the orbit, and it developed a tumor like this and remained like that for 10 years. So this is the typical scenario in India. People present very late. Thank you very much.
Red is inside the eye.
Yes, please. Rice grain growing inside the eye. I have seen thrice. Growing, shooting. The plant is coming out of the seed.
How is possible?
Actually, the rice grain goes inside the eye, lodges in the upper fornix, not much of irritation, and they get enough nutrition to shoot.
Oh, it had not pierced the eyeball.
No. It stays in the upper fornix,
Yes, exactly.
it grows there.
Exactly.
I have 3 cases experience.
Yeah. It's a most of cases, I know, but it's a delayed and neglected case you will see.
Yes.
Ruma Das.
Our next speaker is Dr. Ruma Das, and after that, Dr. Parikshit Gogte.
Now, in the
He's
meantime, if
already
Dr.
here.
Chandana Chakravarti comes, he can give the keynote address anytime. Dr. Ruma Das, then Dr. Parikit Gogte. Yeah. Dr. Parikit Gogte, your turn.
No. Are you ready with the?
Are you ready, Nathan, Dr.
I was going to discuss, so I was.
Okay, because the
Dr. Ruma is, I think.
topic is Dr. Ruma Das, so she is not there.
No, she's there.
Huh? Is there?
She's
Please
there.
do come. I was waiting for you to come, so I am asking.
No.
She's
Actually, the
no,
first,
she will speak first.
first
then
speaker is
she will
Dr. Ruma.
discuss. Dr. Ruma.
Are you ready, Ruma?
Are you ready? She was there inside and see her. Yes. So first talk. This first talk is over.
Dr. Ruma Das is going to speak on pattern of ocular injury during agricultural work in a tertiary care center of Assam.
A very good morning to all. I am Dr. Ruma Das from Silchar Medical College, Assam. So my topic is pattern of ocular trauma in agricultural injury in a tertiary care center in Assam. So ocular trauma is one of the main causes of severe ocular mobility. Decrease of loss of vision, either monocular or binocular, may result in significant economic burdens to families and countries due to time lost from work or school and family caregiving, expensive hospitalization, special visit and treatment, prolonged follow-up, and visual rehabilitation. So, in Assam, in rural Assam, almost 70% of the people are in agriculture, either in farming, livestock rearing, and fishing. So, we have a study from 1st January 2023 to 31st January 2023 in Silchar Medical College, Assam. So our type of study was a prospective observational case series study, and written informed consent was taken from each patient on printed form before examination was done. So visual acuity of each eye was measured by Snellen's chart or Landau's C chart or E chart as appropriate. In patients with poor vision, gross assessment was done by counting fingers at specific distance, hand movements, perception of light present or not, projection of rays accurate or not. In infants, fixation of light and smooth pursuit was assessed with a torchlight. In few cases, pinhole acuity was taken. Ocular motility testing and orbital rim tenderness was done in all patients. Comprehensive anterior and posterior segment assessment was done for all patients. The globe was examined for any laceration, luxation, rupture, any intraocular foreign body, any exophthalmos, anophthalmos, and phthisis bulbi. Any conjunctival foreign body, tear or laceration, subconjunctival hemorrhage and discharge were noted. Corneoscleral injuries, particularly foreign bodies, abrasions, cut injuries, edema, ulcer, etc. were also noted. The posterior segment examination was done either with undilated pupil or with dilated pupil as situation permitted. A direct ophthalmoscopy examination and also indirect examination was done. So, coming to the results of our study, in this prospective observational case series, 657 patients with injury either in one eye or both eyes were clinically examined between 1st January 2023 to 31st December 2023. Out of this, 460 patients were males and 197 patients were female. This is the age group studies. We have found the occurrence of agricultural injuries mostly in the age group of 21 to 30 and 31 to 40 years of age group. Coming to ocular manifestations, corneal ulcer was the highest, 292, that is 44.5%, out of which 227 were male and 65 were female. Then next is the corneal epithelial defect, 122, that is 18.5%, out of which 75 were male and 47 were female. And other types of injuries were penetrating full thickness laceration, embedded foreign body, traumatic cataract, panophthalmitis, some cases endophthalmitis, and chemical injuries only 13 cases, out of which 6 were male and 7 were female. So, injury was more common between 21 and 55 years of age groups in both sexes, which were corroborative with the findings in Singapore study. Males were 74.6% at higher frequency of trauma than the females. Corneal ulcer is a major cause of blindness throughout the world and mostly in developing countries. In our study, it occurred in 227 males and 65 females, which corroborates with the findings of a population-based study in rural South India. So, susceptible population of eye injuries were middle and young-aged working groups, and the proportion of males was higher. The leading two types of ocular manifestations were corneal ulcer and epithelial defect. It is therefore recommended that efforts should be invested in education for proper eye protection in order to prevent ocular trauma in the young and middle-aged working groups. Research and prevention of eye injuries could be further aided by a nationwide collaborative registry of eye injuries in India. These are my references. Thank you.
Thank you, Dr. Uma. Indeed, this is a matter of concern. Okay.
Could you briefly tell us about the type of injuries? I mean, how many cases did you encounter of fungal, ulcers or bacterial one or otherwise?
Yes, sir.
Because that is more important
Yeah,
now
since
in all
this
these
is
cases of
basically
ocular trauma.
Yes.
Yes, sir.
Because you are talking about the agricultural injury, basically.
Can you
So-
please help me? My slides are not come.
And number two, how about the chemical injuries? What was the nature?
So, corneal ulcer we got 292, and out of which 227 were male and 65 were female, and most of the corneal ulcers were fungal corneal ulcers. Fungal corneal ulcers.
Because you are from a medical college,
Yes,
could
sir.
you go for which fungus was there?
Yes,
You must have got it.
Pseudomonas. Yes, we did the study. Aspergillus, Pseudomonas.
Pseudomonas is not a fungi.
Not sorry, sir. Aspergillus. Aspergillus. Sorry, sir. Aspergillus.
How about chemical injuries?
Chemical, mainly lime burn. Lime burn injuries.
Have you seen any kids to be injured? Suppose a 1 year old or 6 months. Have you noted?
Yes, sir. But not is agricultural injuries. Kids are affected by playing with sharp instruments and all. But in case of agricultural injuries, we mostly got patients in the age group of 21 to 55 years of age, working population.
I've seen 2 cases of kids of 6 months and lying in this would be a little tell it, and this big of walk.
Yes,
Certainly.
Yes.
Trauma.
lime injury, lime burn
No,
injury.
no. It's a bird.
I think.
Bird, yes, sir.
Dr. Shekhar, thank you.
Okay,
Now
thank you.
we'll go the second speaker, Dr. Parikshit Gogte. Yeah, he's there to discuss about the ocular.
Thank you, Dr. Samantha sir, Satanshu sir, for giving me this opportunity. Respected chairpersons, Dr. Gupta sir, Dr. Subuddhi sir, Dr. Nepalia sir, Dr. Sarkar sir. I thought I was just had to make comments on it, so I don't have a PPT. But Dr. Das has an excellent series, a very large series of ocular trauma from Silchar, which is relatively in one corner of the country. But the agricultural trauma that she is saying is still widespread all over the country. It may not, perhaps agriculture may not be having 70% of India's working population, but it still definitely has 40 to 50% of the population. And a lot of them are perhaps amongst the poorest in the country, as the farmer protest shows. So they all come to government medical colleges and NGO hospitals. Very few of them go to private practitioners. In the READ study that was done by AIOS ARC, it was found that during residency, Indian ophthalmology residents were actually exposed maximum to only 2 kinds of things. One is for cataract and the other is for ocular trauma. So that way our residents see a lot of trauma. But is it that we really inculcate in our residents how to best deal with it? The area where I come from in Maharashtra, as residents, we would see a lot of sugarcane injuries, because when they cut the sugarcane, the leaf of the sugarcane can actually literally slice through the cornea. And they take it on big truck trolleys, the sugarcane. So if there are 2-wheelers, scooters, cyclists, they also get harmed with the sugarcane. Dr. Heralgi from Shimoga has also shown that he has a publication on areca nuts causing eye injuries because they climb up the trees to pick up the nuts. And Dr. Mehul Shah and Shreya Shah also have large series upon how ocular trauma causes traumatic cataract, and they have in fact designed scales to do with it. So we will get to know what is good outcome and what is not so good outcome. In ocular trauma, we have to understand that perhaps trauma does not come to us first. Trauma goes to mostly the general practitioners or the emergency departments, and they are the ones who see it first, and then only it comes to us as ophthalmologists, especially in places where there are no ophthalmologists or the ophthalmologist is very far away. So I think ACOIN can do one thing in its ocular trauma thing, to have more awareness, like Swapnada had that Drishti Drath. We should have more awareness amongst general practitioners, lay practitioners, and in a lot of places it's the Ayurvedic, the homeopathic practitioners, Ayush, nurses, who give the first line of care. Even if they can do 2 things, one is they are able to differentiate between an open globe injury and a closed globe injury. Because an open globe injury has to be referred to an eye hospital as soon as possible and treated well. For a closed globe injury, even if the referral is done a few days later, it does not make a big difference. And second is not to prescribe steroids, because as ma'am said, there is a lot of aspergillosis, perhaps mucormycosis. And generally, because the steroid antibiotic drops are very cheaply available for 10 rupees, 12 rupees, and the eye becomes white and the pain goes away. So a lot of GPs write that first, or that is the only eye drop they know what to write. And then that causes more of corneal ulcers, which is very difficult to treat. So even if two awareness are done, one is not to prescribe steroids, and second, just to differentiate between an open globe and a closed globe injury, that will go a long way in reducing the morbidity due to ocular trauma. From the community perspective, trauma that way is very neglected because it causes uniocular blindness. So it is never seen much in all the surveys that are done, which look only at bilateral blindness. But as Dr. Das said, in this, most of the blindness is from the age group of 21 to 40, 55, and almost 75% is in males. Now, there is no gender bias in saying, but then at least in rural areas, a lot of men are the bread earners of the family. So if they become blind or they are out of work for whatever reason, it's not just they that are affected, but their entire family is affected in such a way. And they are in their working age group. So in case they lose an eye or something happens, they will carry this burden of blindness for the next 30, 40 years. So that is what makes ocular trauma very important. And thank you again, sirs, for giving me this opportunity.
Dr.
Sir,
Parikit,
I
yes,
want to add one thing. Sir has said in Maharashtra, sugarcane leaf injury is mostly seen. But in Assam, sir, we get paddy leaf injuries.
everywhere. That's what-
Everywhere. That is very
What
common.
I want to say also, 1 minute, I will let me say. Paddy leaf is very common
Yes,
because
sir.
80% of agriculture workers are in our country, and mostly they are doing the paddy. And first thing, they treat self-treatment the first. Second thing is OTC. What is OTC? Over-the-counter drugs.
Over-the-counter.
And whenever they go to the counter, they get a drug which is steroid combination.
Usually, yes.
Antibiotic combination, that's very cheaper. Hardly 20, 30 rupees, they put that. Then after that, they go to a MBBS doctor also, or homeopathy doctor. Even our general practice and MBBS doctors also educated about the ocular trauma, because hardly we speak anything in the MBBS career. They have to also be educated. And fourth, they come to us. By the time it led a lot of complications.
Thank you, sir.
Here I'd like to add what Dr. Parikshit had said, that in Maharashtra, sugarcane injury, crop injury is more common, as you say, pedigree. In Rajasthan, we get number of cases who are working in onion fields. So while taking out the onions or cutting the crop, they get injury. And at times it becomes very difficult as a clinician to start what drug. So sometimes we have to start a cocktail therapy. I hope some of you may not agree, but the situation compels us to start with antibiotic and antifungal, both locally as well as systemic. So that should be kept in mind while you're dealing with a case of ocular trauma. Depending on the nature, the patient has sustained the injury, you have to have your own rational approach for all individual patients. You cannot equate all patients together.
And
So
regarding-
every individual patient requires a rational approach.
Using
Regarding-
of cocktail of different antibiotics is very common,
It's very
especially
common,
at primary level or secondary level. Only in tertiary level you go for differentiating
So we'll
that.
move on to next speaker.
Sir,
Dr. Sunil
regarding
Kumar.
chemical injuries,
Yes.
lime burn is more in Assam because we
No,
used to
everywhere,
take
it is everywhere.
betel nut,
Everywhere.
pan and betel nuts.
Yeah.
Okay, thank you, sir.
Yes, sir.
Actually, this is regarding only one area. There are different publications across the.
Sir, mic is there. Yeah.
There are different publications across the country. So we don't have real authentic data about the country. We tried to do this registry for n number of times, but that is not happening. There are many obstacles to that. And number one and number two, since even it was done in the medical college, but I could not find the BETTS classification because more than 50% of the injury was were lamellar laceration, not the open globe, which were not handled well, so they developed the corneal opacities and ulcers. If they would have handled earlier, that would have made difference. Thank you.
Thank you, sir. Dr. Sunil Kumar, next speaker.
Sir, from my experience, I can tell you that sometimes open globe injuries are less notorious than the closed globe injuries as far as the management is concerned and post-traumatic morbidity is concerned?
We have published data in Graph Archives of Ophthalmology with
Yeah.
open and closed globe injury. Open globe
So,
is doing better.
I think we'll move on to next talk. If the Dr. Sunil Kumar is not here, so we'll move on to the next talk. It is iatrogenic trauma IOL drop by Dr. Soni Sinha.
Dr. Soni Sinha.
Dr. Jayashree Dora and Dr. Pradeep Mahanta, the discussants are there? I think they are not there, so we can have a little bit more time.
Dr. Soni Sinha is from AIMS Patna, and she has been a very good academician.
You can come closer.
Yes, it's all right.
A very good morning to the august people on and off the dais. I'm here to speak on iatrogenic trauma, and specifically IOL drop. Excuse me. There are no financial disclosures to make. Now, IOL drop is actually complete dislocation of the IOL into the vitreous chamber, which may be either intraoperative or postoperative, and this may again be early or late. Intraoperatively, that
Excuse me,
attempt to implant.
may I call Dr. Inder Mohan Dustagi? Please come in the front seat. So you are one of the moderators. Thank you. Yes, Dr. Soni.
Excuse me.
Carry on, madam.
So this usually occurs intraoperatively on attempting to implant an IOL in the presence of PC rent or zonular deficiency. So this can be either intraoperatively or pre-existing. So as in this video, you saw that a sulcus lens was being implanted, dialed, and the visco removed. And as soon as the wound is getting hydrated or moxifloxacin is being put, the lens is already tilting, and hey presto, the lens lands at the bottom of the vitreous cavity. So post-operatively also it can occur either early, within 3 months, when it occurs due to, when the IOL haptic is rotated away from the area of capsular support and left as such, or it can occur late, after 3 months due to trauma, progressive zonulopathies, vitreoretinal surgery, or a progressive contraction of the anterior capsule. So there are many predisposing factors, including pseudoexfoliation syndrome, retinitis pigmentosa, diabetes mellitus, aging, axial myopia, etc. And the diagnosis and investigations entail taking a good history and examining all previous records of the patients, including those of treatment, taking the BCVA and intraocular pressure, assessing the cornea for future lens implantation, assessing the residual capsule, doing a good indirect ophthalmoscopy with a scleral depression, going in with investigations such as B-scan, ASOCT or UBM, taking a specular count, having a macular OCT and a biometry if we are planning to implant a lens to have a good prognostication, and to distinguish between in the back dislocation versus IOL dislocation alone. So the prevention would be to avoid implanting a conventional PC-IOL if the status of capsular rim is uncertain, and to inflate the inferior iridocapsular sulcus with viscoelastic to accommodate the leading haptic, and leave the superior haptic in the sulcus and check the stability of the IOL before leaving, and avoid dialing the IOL too much in case of extended rhexis. The complications include vitreous hemorrhage, retinal detachment, CME, and cyclodialysis. We have for the management a choice for observing some asymptomatic patient or patient without inflammation, if the IOL is non-mobile, not having any retinal complications, or if the patient is just satisfied with his aphakic correction, or there's, surgical intervention just cannot be done in a non-consenting patient. But the proper management would be a surgical approach, when either you can do a PPV with or without a PFCL, that is perfluorocarbon, lifting the IOL to the anterior chamber and placing an IOL over if possible. The same IOL can be repositioned in the sulcus, or even scleral fixated in case of a 3-piece IOL, or a sulcus fixation in a 1-piece hydrophilic IOL. Or the other options of putting in the IOL would be iris fixation, scleral fixation, or an ACIOL. It all depends upon the status of the cornea, iris sclera, and comfort of the surgeon. But assisted levitation is really not recommended. So this is a video where you have a rigid IOL, UV blocking IOL, where the triamcinolone is put in, a vitrectomy is performed, and PVD is induced, and just around the IOL is mobilized as best as possible, and then finally the haptic is caught with that of with an foreign body forceps, and the IOL is removed via the anterior route, being a rigid IOL. This is the second video is that of a foldable IOL in the mid-vitreous. As the vitreous is mobilized, the IOL falls back onto the macula. So to protect the macula, a PFCL is injected. The IOL floats upwards and of course peripherally, because the upper surface is convex, and finally is taken out by the same anterior route, by the handshake technique, and then finally folded up within the anterior chamber and taken out through a relatively smaller incision. So, and the ports are closed. So, the prognosis regarding iatrogenic trauma and after taking out the IOL would be that 85% have been known to achieve a visual acuity of 20/40 or better. Pre-existing disease leads to unfavorable outcomes, and close follow-up and management can help to avoid the above, and cautious pre, intra and post-operative assessment are required. Thank you.
Madam, when I really compliment you for a wonderful presentation. It's an eye-opener for most of the audience present here in this August gathering. My point is that would you like to highlight about scleral fixated lenses in such situations?
Sir,
You have not a mention of that. Scleral fixated implants, where you're explanting the IOL
and yes, that was
posterior
what
iris
that
claw
is.
implant.
Of course, if when you're implanting, then also it can drop. When there have been drops of scleral fixated eyes during the implantation also. So, and if
These are the different modalities, of course.
After the removing that lens, you can place another scleral fixed lens. Nowadays,
that is true. That is true.
Right there.
So rehabilitation, yeah.
Yes, sir.
It could be primary, it could be secondary
Yes,
also.
sir. One of the slides it was there.
So,
Iris fixated lens.
Iris fixated can be anterofixated or retrofixated, preferably retrofixated to take care of the endothelial count. Yes, we can do that.
Thanks, Soni. And the next speaker, Dr. Pradeep Mohanta.
Discuss on this topic. This topic. You are a discussion for this topic for 4 minutes. Please come here.
मैम से एक दो क्वेश्चन तो पूछा सर.
किसको? मैडम.
हाँ, इसका एग्जाम दे रहा हूँ.
पूछिए.
Sorry, I was late and I just saw the last 2 minutes of the video. Ma'am, if we plan posterior iris claw lens, then we can make a scleral tunnel and we need not fold the IOL in the anterior chamber. Folding the IOL in the anterior chamber is more manipulations. There can be touch of endothelium by the lens, by the forceps that we use to fold the lens. So better we make a scleral tunnel, remove the IOL through a wide tunnel, maybe 6 mm, and then place a PMMA retro iris fixated lens. That will be a better option. Any other questions so that we can discuss?
We can use a different type of scleral fixated lenses.
That is
The innovative, we have fixated lens of scleral duct lens, which is self-sustainable, and as well as that does not require glue or suture. We have published that in AIO, and we have done more than 300 cases now. That can be done. That can be done in post-trauma as well as post-iatrogenic cases, and even in presence of this and following endophthalmitis, we have done at least 10 cases, and they all are doing great.
So I think more than 30 years experience we have in this field, and looking at the published literature also, I think these surgeons should be versatile. They should be able to do multiple things, and the things are evolving. Last time in our innovation center, we had somebody who took out the lenses and they actually redesigned the lens on the table and then could implant the same. So they redesigned it into the type of lens that you told. So so the field is very versatile, and the type of trauma, the iris, cornea, astigmatism, So many factors are there. So I think people who are dealing with this, it should be sort of a specialized person who does the surgery. When the IOL drops, it's not an emergency. It's not an emergency to go ahead and fish it and try to fix it somewhere. Even I have fished out 3 IOLs from the same eye. One has dropped, second has dropped, still that surgeon is putting one more third one. Now when the third one is there, how do I remove those 2? Now I have to remove all 3. Now when I am removing all 3, how do I charge the patient? So IOL explant, I charge something. Then I don't want to charge the same thing to removing 1 IOL to removing 3 IOLs. Then I put foreign body removal charge. So it becomes very messy. Only message I want to give is this is highly specialized area. There is very good outcome if the surgeon knows what they are doing, and that practice should not be left to somebody who has just done 1 or 2 cases. They should learn different techniques, and sometimes it is glued IOL, sometimes it is SF IOL. Yesterday only somebody showed a case where the IOL was dropping and they removed and they put a single piece IOL in the sulcus. Now we know that single piece IOL doesn't have to be put in sulcus. They will get glaucoma. That patient got 0.8 cupping and 40 pressure for 3 months before she came to us. And it's sad to say that already it has been taught don't put single piece IOL in the sulcus, but somebody is putting just because they want to put it. So I think if IOL drops for whatever reason, just stop, give the steroids, give the pediatrics, send to somebody who knows different techniques, and then they will put a good IOL. The literature shows there is no one method better than the other. All methods have led to good outcomes if they are done properly.
So I think relevance of this presentation in relation to community ophthalmology is that we must have a meticulous preoperative counseling of each and every patient. That although we are going to do our best for you, God bless me and you both. Because any complication can take place at any stage of surgery. And what Madam has highlighted, that at times you have to explant the IOL, go for secondary IOL. And if the patient is fussy, you are in trouble. So I think meticulous preoperative counseling is an important part of every surgery.
Always keep it with guarded prognosis and never make tall claims. That is very important in these cases.
May I ask one question to the House?
As this conference is going on in Calcutta, just I recall and remember one incident of this IOL drop. What happened about 25 years back that make a big event cry in Calcutta, in one of the advanced center in Calcutta, in a medical college in Calcutta. The HOD has operated the case. The first IOL was dropped, second IOL was dropped, and still he put an AC IOL. So there were 3 IOL in the eye, and patient has got not beautiful vision, anything. Then it gone to the Consumers Protection Court. So for long 5-6 years, it has gone into the public, it has gone into Consumers Protection Forum, as well as up to the Director of Medical Education. And finally it was solved that a surgeon cannot put more than 1 IOL on the table inside the...
But you cannot do law. You cannot put a law like that, you don't put the second IOL.
No, in the presence of another IOL within the eye.
This was just like buy one, get 2 free.
Okay, my question is, suppose you have done, the IOL has dropped and you want to refer the case to a VR surgeon, and the VR surgeon knows both scleral fixation of a multipiece IOL like sensor multipiece and posterior iris claw lens. Which one you will recommend to your, to the surgeon you are referring to?
Sir, I think we should leave it to the retina surgeon. However, if at all that person has got any retinal issues or likely to have any retinal issues, better try to put in a scleral fixated IOL. That is for the vitreoretinal surgeon, not the surgeon. We should not be recommending that you put and do this or you
nothing
do
should
that.
be taken in a
I think
hurry.
it should be left on the retina.
Nothing should be taken in a hurry to take decision.
So
Because maybe
the
later on
question is,
dilatation will be required, and with an iris fixated, maybe it won't die that way.
Each case is different from the other case.
okay, is it that the long-term result of scleral fixation IOL is better than posterior iris claw lens?
Not only that,
If it
sir.
is sutured, then
Definitely.
it's a problem. So now people are not suturing. We are doing glued or we are doing the method that he told, which is sutureless. So the proline sutures break after some years. That has been a problem in about 15% cases. That's the published data. So that is something which people have to redo.
So glued IOL where the haptic is placed in the...
That will not drop. No? There's no suture.
We have done a comparative study and we found no significant difference in long-term rolling sutures gets disintegrated and
Yes.
those IOL drops.
Yes.
But the cortex suture availability is still the problem.
Yeah. Okay, I think.
One comment I want to make in this regard. One comment is, see, these multiple IOLs are put just to save the face of the surgeon.
It doesn't.
Yeah, normally it is done because he has to face the patient and patient party. So he goes on putting. Now, it's better if you have good rexis, you can put the lens in the sulcus. And nowadays, good vitreoretinal surgeons can remove, even if there is if you have done good vitrectomy, anti-vitrectomy, and put the lens in the sulcus, there is no problem. They can take out the lens from the vitreous very easily. There is absolutely no problem. No. I mean, they can do it.
One more point in relation to your, query, that accidentally if there has been a associated RD with a dropped IOL, and if the VR surgeon has taken care of RD and if he has put in silicone oil for the internal tamponade, then I think scleral fixation IOL is a better choice compared to a posterior iris claw IOL.
So what I think is the VR surgeon has already spent a lot of time doing the other parts, vitrectomy. And this glued IOL will take another 15-20 minutes. And the iris claw will take 2-3 minutes.
That is not the point, sir. Point is not that of how much time the surgery takes. We are more, keen about the prognosis of the case.
Yes, but the
We
surgeon,
don't look at
to
the
save
watch, we look
time,
at the patient's
will go for
condition.
posterior iris claw
Yes.
rather than scleral fixated
But it has
IOL.
been seen,
Can be
Dr.
situations
Pradeep,
like this.
Time is not the factor.
Time is not a factor. It should not be a factor.
You
Yes.
spend 2 hours, why not another 15 minutes? That is not the issue. Question is, which is the best?
In the second sitting, while you do the SOR as well as SFIO.
Yes.
SFIO. This
You
is
can
how we
take time and
How many
seconds.
days can we wait if we don't put in the same table?
So we can wait for even for 3 months. If let the eye be quiet.
Once inflammation subsides, then you can go.
I have made a patient wait for 3 months. Cornea is crystal clear. Then I have done scleral fixated IOL.
Not only that, sir, if the patient is apprehensive, anxious, we can even plan for surgery, this second surgery under GA. Never make it a point of issue that I'll do it under topical or I'll do it under peribulbar. If the condition demands so, one must always think on lines of giving GA to the patient.
And
then we-
so
we
one
move
more
on to the
point
next
that
talk-
I did
next
not
talk.
make.
So may we conclude before
For
the next
posi-
talk?
For positive types, I didn't make one point, and this is very important for colleagues to, battle for the colleagues. Not that there's something stray remarks are being passed by the second surgeon. That should not happen. And the other one is that the patient should be very adequately counseled by the first surgeon, and the second surgeon should corroborate that yes, whatever could have been done has been done for you.
But one thing I would say, they should not pass any comment against the other surgeon.
Yes,
That's
That's
very important. Yes, that is very important. Most
That is very important, yeah.
So may we can conclude that the scleral fixated lens means the haptic is fixated in the sclera is much better than any other scleral fixation lens.
Right. Sure.
Thank you.
Okay, thank you very much for the good discussion on this topic. We move on to the next talk. Myths and facts of open globe injuries in RTA. It's Dr. Subhadra Jalali.
As everybody knows, Dr. Subhadra Jalali is a renowned ROP, especially. She has got a very good name in the country and outside also, in the world also. So she will be speaking on myths and facts of open globe injury. Thank you.
Yeah, I deal with trauma also. So let's see some of the myths and facts of these things. So these are the important things, especially from the community point of view, that if there is no light perception, this we learned from the Israeli group on trauma, who have done a lot of work on trauma, being in the war zone all the time. Same thing for us in Kashmir. So if you check the no light perception, which we are taught in medical college or in our ophthalmology residency, has to be done with an indirect ophthalmoscope. So it is presumed that the indirect ophthalmoscope light is the brightest light, and that is why it was mentioned. But we did a study where we used the ERG flashlight, and we found people who were not responding to no PL with the indirect light actually responded to the flashlight of the Gansfeld, which is like really 10,000 times brighter. So just to say that this no PL is a subjective test, there is no objectivity to it. Patient is in trauma, they may respond, they may not respond, and sometimes they, because the eye is full of blood, so they can't actually see the light like we see in a normal eye. So we ask like light dikhta hai, nahi dikhta, he'll say nahi dikhta, but sometimes they can see a glow. So now glow is different from light dikhta hai. So what we are asking, what the patient is telling, so this no PL should not decide what treatment we are going to give. So I have so many patients where somebody wrote no PL in the emergency, and after proper treatment, patient has got 20/40 or 20/100 at 6:36, even 6:12 vision. Why this happens? That's what exactly I'm saying, and there's published literature also. So while we do document PL, no PL, but the treatment should depend on what is the pathology of the tissues. So this is one myth I want to break. Of course, people who come with PL, no PL vision, their prognosis would be poorer. It's not that all of them are going to get vision, but that is not what should decide our approach to the patient. Second is hypotony. So whenever there is a detachment or there is an open globe, or even if you have repaired an open globe, because of the underlying detachment, ciliocoroidal, retinal, patient can have hypotony, so pressure can be 0 or non-recordable. That does not mean it is phthisis. Just because the eye is looking smaller or the pressure is 0, it is not phthisis. Phthisis takes at least 5 to 6 months. It's a pathological diagnosis where the tissues are replaced with fibrous tissue, calcified tissue. So that's a very different disease. In acute phase, we should not label anything as pre-phthysical, going into phthisis, become phthysical. So we should just say this is hypotony. And hypotony we need to manage by putting silicone oil, by doing treatment of the cyclodialysis cleft, by putting back the retina in place, by looking at any wound leak. So there are various causes why the eye could be severely hypotonic, inflammation. So we must treat that hypotony and treat the pathology and not label it as pre-phthysical till it really is pre-phthysical or phthisis. The other thing is like only little is gained and much time and effort and money will go into the surgical repair. So if there's a big wound and there's sort of PL, no PLI and all. So people used to do primary enucleation because or primary evisceration, saying that now we are going to save the sympathetic ophthalmitis. This is completely not acceptable in today's microsurgical era, where we can really salvage a lot of these eyes if we do the proper thing at the proper time. And you never know what will happen to their good eye, and the risk of sympathetic ophthalmia is very, very low. And even if sympathetic ophthalmia occurs, it is treatable. So we should not do any primary enucleation. We should always give a chance to that eye to recover, to repair, and then once you've done the primary work for a few weeks, months, then you make the decision whether there is, it's unsightly, it's really phthysical, and then make the decision. But otherwise, most of these eyes, if you repair properly, they can get useful vision or even globe preservation. Now the other very important myth is that कि आपको तो चोट लग गया इसलिए आंख खराब हो गई. So to say that most of the damage has occurred during the impact, and the surgeon has no role to play for the ongoing damage. So this is a very important concept, that the trauma is there, it's a bad case, it's a road traffic accident or whatever, it's very badly slashed eye, but there's an ongoing damage which is happening, which the surgeon can stop by doing the immediate primary repair, by giving lot of steroids, giving antibiotic in case we are thinking that there is going to be endophthalmitis, giving intraocular antibiotic during the primary repair. So if you do these steps, then you are preventing ongoing damage. So the primary injury is there, but there is an ongoing damage from inflammation, from infection, from open globe, and from not doing the proper thing. So the surgeon, the primary surgeon who's seeing in the field, has a lot of role to play, including, of course, without saying, giving an injection of tetanus toxide. If it is open globe injury, that's mandatory, legally mandatory to give tetanus toxide by the person who sees the patient first. There are other myths and facts, which is like vitreous hemorrhage can be followed up. We should do blind cryopexy. all blind eyes have to be enucleated, and most important that after injury patient should be on complete bed rest, otherwise the retina will detach. No, the retina doesn't detach because of physical activity. It's a biochemical nature of the injury and the biochemical adhesion of the retina to the RPE which makes it attach or not attach. It's not like by walking or running the retina is going to detach. So these are some of the myths I wanted to break in my presentation. Thank you.
I think ma'am has very elaborately conveyed a wonderful message for all of us that a surgeon must have the courage to deal a situation where you feel that the prognosis is very poor or you are desperate. But we should have the courage to beat the situation. Number one. Number two, madam, I wanted to know, you have recommended enucleation for all blind eyes.
I said no. I said there is no recommendation for. I said people think. Yeah.
It's the other way around.
Yeah. So because of lack of time, I didn't show cases.
In a case of sympathetic ophthalmitis.
That's what I said. I said in the past, the past, that is what people used to counsel. That's a myth. That's a myth. Don't remove these eyes. Let them be there. Good cosmesis can be achieved, and the risk of sympathetic ophthalmia is not there if you have closed. So for the primary surgeon, important is to get that wound to be closed. And then what we find is that they refer the patient after a month or so. That's not to be done, because the second surgery for the retina must be completed within 10 to 15 days. Then only you can salvage that eye. So do the primary repair, start on systemic steroids, start on oral antibiotics if you want, start on oral steroids, heavy dose, and then immediate and topical 2-hourly steroid, and immediately refer to the vitreoretina surgeon. So they will evaluate, and now because of endoscopic surgery, because of good what we say small incision vitrectomy surgery, we are able to operate them within 7 to 10 days, and that is the best time to do the retina surgery. If you send after 1 month, then the retina has already got completely scarred.
Provided media is clear.
No. Even in unclear media, we can do primary PK, we can do endoscopic surgery. Now endoscopic vitrectomy, in many of the centers it has already started. We are doing for many years. But in good centers, we will have endoscopic surgery. So even if cornea is opaque, we can go from behind and do the surgery and not do a PK. Endoscopic vitrectomy.
Many times the root traffic accident cases, two things happen. From the medical legal point of view, the people, whoever they're not touching the cases. They report late. Second thing, it's reported, once it's reported by the primary care physician, what he has to do.
Yeah.
Before he's referred to the ophthalmic surgeon.
Yeah, so they have to make sure that patient doesn't have head injury, all those points like CSF leak, any history of vomiting, because sometimes they land into ophthalmology OPD without having seen a neurosurgeon or neurophysician. We cannot take them up. So so the life is priority, the CNS injury is priority, they could be chest injury, they could be having breathing problem, they may die in your OPD, in your emergency. So that primary first aid and assessment of the patient that there is no other vital organ injury, liver rupture, that can be silent, patient can die there. So all those things the general surgeon, neurosurgeon has to evaluate, do the CT scan or do the abdominal ultrasound or whatever. That is the priority. So even if they come to your eye hospital first, you put the IV line, stabilize and send them to the main hospital.
That's a wonderful message.
Yeah, that is very important. Life has to be taken
cases,
first.
We should have a multi-specialty approach. You cannot bank upon your own specialty.
Yeah.
Look to the general condition of the patient.
Yeah,
look into
BP,
the
pulse,
history part
and document it.
And decide
Yeah.
if the patient requires opinion of other specialists, go for that.
Yeah,
we know. Team management.
Yeah, we know bleeding through ENT. This is taught in MS. Bleeding through ENT, CSF, right? Unconsciousness, all these things we have to send there.
May I request Dr. Mayul sir to come and give your comments on this, discuss?
In an open globe injury, usually we don't put an antibiotic drop. Usually we just put an eye shield or an eye pad so that people don't put things into the eye and then do the repair usually within 4 to 6 hours. And if it is less than 12-hour injury, give intracameral or intravitreal antibiotic, vancomycin, at the time of the primary repair.
But directly antibiotic drop is not given.
Antibiotic drops we should not put because we don't know what is going inside the eye.
Yeah. Thanks, Dr. Subhadra Jalali, ma'am. And to carry forward this topic, I invite Dr. Mehul sir to discuss it. And after that, we will have discussion by Dr. Tariq Qureshi also. Yeah.
It was a wonderful insight by Madam. She shared her experience, and then we all are benefited greatly by her presentation. So I would like to highlight few points. First, we talk about the no perception of light. We have a publication for 429 eyes where 29% patient recovered ranging from hand movement to 612 vision. That is published. That is the reason, particularly in children, the new prognostic score which has come as a toddler ocular trauma score, that is based on objective findings, not by asking the perception of light and not by the it is by a clinical examination. Regarding hypotony, when it is hypotony, amongst all reason, there may be some occult wound which need to be explored. That is one most important primary part. If not done and still we cannot found, we can disinsert the recti and then we can look for the place. Even if we don't treat, if the primary person does not treat, medical treatment may help, because as she already highlighted, a lot of systemic steroids and all other medical treatment, or in case of infection or open glove injury, maybe intravitreal injection while repair is mandatory. Even if we have endophthalmitis in no perception of light, that may be because of optic neuritis. Along with we have experience and we have published the data that even in no PL in endophthalmitis, following vitrectomy, following scleral fixated lens, patient regains very good vision. Cryopexy, as you said, blind cryopexy may not be recommended, but in zone 2 or zone 3, if there is no gross we can see the retinal damage, then cryopexy may be helpful. And regarding the timing of vitrectomy, the current concept in traumatology is if you do vitrectomy within 100 hours, that's much more beneficial. And I think we have article in International Ophthalmology Controversies of Ocular Trauma that highlights all these points. Thank you.
One point I also want to make, if the patient has undergone any surgery in the past, like RK or SICS or FACO, then, so this I wanted to highlight because I'm seeing this misconception again, myth. So if patient has undergone any intraocular surgery in the past, then any ocular trauma, even if it looks like a closed globe, we must explore, because especially with FACO and SICS wounds, that injury could be under the conjunctiva and it could be occult. But I have seen people, not opening that eye and giving steroids and all, and then, patient coming to us after 2 weeks and we see the IOL is dislocated, the iris is in the wound, but it's all covered with conjunctiva.
Pseudophacosil.
Yes, so any eye with past trauma, past surgery, if they have any trauma, it could be trivial trauma, please open that wound site and make sure that there is no open globe.
We have come across also one IOL in the subconjunctival space.
Yeah, pseudophacosil.
Yes, pseudophacosil, yes. Pseudophacosil. So may I invite Dr. Tariq Qureshi to speak on this topic? Dr. Tariq? Achha, okay, please. Thereafter, okay.
So then we have 3 minutes presentation by of interesting topic. Dr. Manpreet Kaur is there. She is not there.
Yes, she's there.
Oh yes, she's there.
May I request all speakers to stay back? So we'll take a group photo at the end of the session. Yes, yes.
And the next is Dr. Bileshwar Samanta.
Please, this side.
You can prepare yourself for the next podium. Yeah.
Okay, so good morning everyone. Thank you Dr. Samanta for providing me the opportunity. So I would be presenting a unique case, an unusual foreign body. So this was my reaction. My brain was like, what and how could this be possible? When I received this picture from a resident that a child has been brought to the emergency with such a foreign body. So this is the foreign body, you can see dangling from her eye up to the shoulder. So she was a 9-year-old girl, a child of a laborer parents, and she was referred to us from somewhere. She had a history of fall on a pile of wires while playing, and on examination we could see there was a 16 centimeter long metallic wire, 2.5 millimeter in thickness, into the superior temporal fornix. And interesting is to know that the other end of the wire, which was on the shoulder, it has a hooked end. So since the child was very uncomfortable on the movements, as well as she could not move her head or neck. So we decided to cut it short before sending her for CT scan examination, and we cut it with the K wire. And so this CT scan imaging is showing a shorter segment wire. So you can see the axial imaging and the coronal image. And on the axial imaging, it is interesting to know there are 2 points. So the 2-point reflectivity showed that it may be an hooked end which is inserted into the eye. So there was a metallic foreign body 3.5 centimeter long with the width of 2.5 millimeter lateral to the right eyeball. Luckily, she had no eyeball injury, no injury to any extraocular muscle or the optic nerve. And this body was partially in the orbit and partially outside the orbit. The bony walls of the orbit were intact with no fracture, and there was a mild periorbital soft tissue swelling. So we decided to explore it under GA and to remove under GA. So this is a short video. So we make a parotomy. We made a conjunctival incision around the foreign body. We fixed it with the help of an artery forceps, and with slight rotatory movement we tried to find out where the other end is inserted or it is impaled or hooked. So with little manipulation we could see the hooked end, the angled part of the foreign body. It is apparent now, so we tried to clear the conjunctiva around it. Now we can clearly see that end, and with the help of I just rotated it so that it becomes more obvious, and then we inserted and we placed another artery forceps just at that angle. You can see that the end is now coming out, and with another artery forceps and slight rotative movement, it was removed. We washed it and we sutured the conjunctiva. And this is the segment of the wire which was removed. And this is the first day picture of the child, happy child, full eye movements, no pain. Thank you.
It's good, excellent.
What was the visual status post-op?
So she was good. She had no vision. She was 6 on
So
presentation.
it retrace the railroad method. The way it has gone inside just to come out that
Yes,
way.
yes,
Then
yes,
only
yes.
it's
Yes.
yeah, without causing.
Everything helped because it was an extraocular
Pardon?
injury.
Tissue kind of thing.
The,
Yes.
thank you, thank you.
Thank
Dr.
you, sir.
Bileshwar, next
Dr.
case.
Bileshwar Shamanta. Yeah.
And Dr. Sonam Burma to ready on this side. Dr. Sonam Burma, Dr. Shivangi Singh, Dr. Abhishek Onkar. Please come this side and give. Yeah. Dr. Bileshwar, yours.
Good morning, respected Chairman Sir and the honorable delegates present here. I would like to present a very small paper before you on a glimpse of ocular trauma cases encountered in the secondary eye care center in Sundarban of southern part of West Bengal. Diamond Harbour Government Medical College is situated in the Sundarban area of southern Bengal. Here I like to show average monthly attendance of admitted cases of ocular trauma in our hospital from month of August to September. On an average, 20 to 25 cases admitted every month in our hospital. I will discuss the summary afterwards. You know, football is the favorite game of rural Bengal. So, in the time of football game, there is a blunt injury occurred in the eye. Road traffic accident is the commonest cause of ocular trauma by bicycle or motorcycle ride. Injury by firecrackers during festival. Acid injury is a part of physical assault or accident. Domestic injury during household work. Injury by thorn of death during collection of the palm juice is also an occupational hazard. Fish hook injury during angling in village ponds also occurs sometimes. Physical assault following political, communal or family affairs very common in this particular area. In a nutshell, the pattern of ocular trauma shows as follows: road traffic accident is 30%, domestic is 20%, occupational 50%, physical assault also is 15%, games 10%, accidental is 5%, and others are 5%. If we go through the parameters of the study group, then age distribution more than 50% were between 25 to 40 years of age groups. 70% were male, most found, and they are urinatorily affected. But fortunately, 70% of these patients used to report to the hospital within 6 hours after the afflictions of the injury. Almost all cases were managed in our hospital, 1 or 2 cases referred to RIO. Blindness is very rare. The partial loss of vision only in 6% cases. So, in conclusion, I can say the major cause of ocular trauma requiring hospital admissions are road traffic accident. The other causes of ocular trauma are domestic, occupational and physical assault. The minor causes of ocular trauma are accidental games and others. So the take-away message is protective measures to safeguard eye during driving, working and other activities. Those are helmets and goggles, etc. Quick reporting to nearby eye health care service center. Public eye health awareness to prevent ocular trauma. Thank you.
Yes. Quick reporting in the, yeah, please tell.
A very comprehensive presentation. Very comprehensive. Compliments to you.
Excellent, excellent presentation. So next speaker, Dr. Abhishek Onkar and Dr. Purba Srivastava. Please come this side and wait for your turn. Please. Yeah.
Respected chairpersons, seniors, colleagues and fraternity. Good morning to you all. So my presentation is regarding a blunt...
Change the slide. Slide is not coming.
Sir, it's there. अच्छा, यहाँ पे change हो गया.
No, ये नया.
Yeah.
Yes.
So it's like a case of intractable glaucoma, angle recession, post-traumatic glaucoma, which was managed by walls. So refractory glaucoma, as we already know, which is uncontrolled by medical therapy or which has failed one or more incisional surgeries, failed on cilioablative procedures, neovascular glaucoma, and mainly something which actually can hamper a surgical outcome with a trabeculectomy. So management options are many, ranging from microinvasive to the traditional glaucoma surgeries, and some latest like the drugs which have also been tried in the trials and successfully so. So this case was a 34-year-old male who presented to OPD with blurring of vision for distance in left eye for 1 year. It has been progressive with intermittent episodes of pain, and there was a history in the left eye blunt wooden object trauma 6 years back. So visual acuity in left eye was 6/18. IOP was high when the patient presented to us with a widened ciliary body band with gonioscopy and an isochoria and slightly dilated sluggish reaction pupil with a cup-disc ratio of about 0.8 to 0.9 with angle recession that we tried to document and the perimetry of the patient for the left eye. So with this clear-cut diagnosis of angle recession glaucoma in left eye was made. Treatment options were, as I said, are many and we already know about it. And the medical management part could not cater to a patient's need. So like mainly we go for a TRABs usually in these cases, but in this we did a search, literature search, what can be best for outcome for this patient. Like this was a case which was actually when I was posted in Andamans, and the patient has actually need to be referred if they are not dealt at time. So it was like a one-go surgery, and luckily we had an access to beveled walls through an NGO. So a literature search actually mentioned that implanting a beveled or Ahmed glaucoma valve in the first setting itself could actually provide some good results for this patient. So we went ahead with that. Prior phaco followed by the implantation of a beveled valve with trimming 8 millimeter, the normal procedures, and with a scleral tunnel, the insertion was done. Post-operatively, the patient's visions were like okay, and IOP were controlled. Like the patient had been in follow-up since then, though I have left that place, but that patient has been in follow-up. So to conclude, traumatic angle recession can lead to intractable glaucoma. And if we have access, the only limitation I would say is an access to the devices and the cost. But now the costs have also drastically reduced. So there can be a first-line treatment for these intractable glaucomas in a case of post-traumatic angle recession. Now that again is like open to discussion. Thank you.
Thank you. Now it's Purva Srivastava for her presentation.
Good morning, respected.
Dr. Pratik, please come here.
respected dignitaries on the dais. I, Dr. Purva Srivastava, will be delivering this brief theoretical talk on the topic of ocular trauma from a resident's and a trainee doctor's point of view. So, ocular trauma is something that we very commonly see as a medical student, as a postgraduate student, or as a fellow also. So, whenever a trauma case comes to us, we are asked by our mentors or consultants to first take a good history and also ensure the systemic stability and then classify the injury that is there in front of us. So, we have very specific terms given to us by the Birmingham Eye Trauma Terminology System, in which we classify the injuries as closed globe and open globe. Closed globe is further classified as contusions or lamellar lacerations. Open globe injuries can be divided as rupture or lacerations, and lacerations are further classified as penetrating, perforating injuries, or the ones with intraocular foreign body. The various mechanisms, we are already aware of them, could be thermal, chemical, or mechanical. So this is just a very this is a flow chart depending on how we can take the history, and upon the slit lamp examination you can conclude that what kind of injury we are actually going to deal with. So now we are going to move to the ocular trauma score, so that we can have a better idea of what we are dealing with and how we can explain it to the patient that what we are actually expecting from the surgery also. So the points are given as per the presenting vision to us, and also the associated findings that we are getting in the patient, and then we make a sum total of the points, and depending on that it's a kind of a prognostic score that we have. So then as residents we are supposed to move to the counseling part, which is very important before taking up surgery or any kind of treatment that we plan to do. And like ma'am said, that it's important to ensure the systemic stability of the patient. So particularly in a setup like a medical college, we need to take help of the neurosurgeons or ENT department or anesthetist also, so that before taking the patient in the OT or in our department, we should ensure that the patient must be healthy and alive. So moving on to the examination part, as a resident we are supposed to carry out the visual acuity first, then moving from front to the back we are supposed to see the pupil, IOP, the motility, full external inspection of the lids, adnexa. So what are the findings that we usually see? We can just come across something simple looking like a subconjunctival hemorrhage or a chemosis, to more complex forms like a conjunctival tear or a dislodged foreign body, like we have already seen in other presentations. What about the corneal injuries then? There could be a foreign body enlarged in the areas of Madhya Pradesh. We very commonly have the iron foreign bodies. So depending on the kind of injury that we are presented with, we are supposed to deal with it promptly and also explain to the patient that what we plan to do. These are some of the pictures of the cases of corneal tear repairs that were done at my center. So we repair the corneal tears as soon as possible, that is within 24 to 48 hours of presentation, and then suture removal is done subsequently within 6 to 8 weeks in children or 2 to 6 months in adults. So since due to the lack of time, I'll just be moving through the slides. We are aware of the chemical injuries as they're very commonly seen in my area also. So this was just an image of a picture at our center which had come with a corneal
Can
tear.
you conclude?
Yes, sir.
Yeah.
Okay.
Last slide, please.
Yeah.
Last slide.
So the just of the briefly, sir, of the cases is just about the proper examination and how we are supposed to deal with the patient expectations also as a resident.
Okay.
It was supposed to be only 3 minutes presentation. Anyway. Yeah.
Thank you very much. I think we'll move on to next. Dr.
Pratik Nishant.
Pratik Nishant, then Dr. Anjit Paul, please come here and stand.
Esteemed panel, ladies and gentlemen, good morning. This is a very brief presentation on traumatic start here with the lens back complex extrusion. We were just talking about the pseudophacoceal, and this is a complete lens back complex extrusion, and somehow the patient recovered good vision. So no financial disclosures. To introduce, injuries to the globe are commonly seen in road traffic accidents, and there are many cases reported wherein the phacoceal is found. The post-traumatic subconjunctival IOL dislocation is also found, and herein we are reporting one such case. So a 53-year-old male presented with pain, diminution of vision and inability to open the eye for 3 hours following the trauma with the rear view mirror of his motorcycle, which was hit on the rear by a truck. So this was in the peak of the first wave of the COVID pandemic. On general examination, the patient was stable. On ocular examination, the vision was pH positive with an inaccurate PR and with a complete ptosis with watery discharge and blood clots. A translucent globular mass was seen in the conjunctival sac with nasal bulbar conjunctival laceration with an occult underlying scleral laceration. So this is the anterior segment photograph of the patient. And the anterior chamber was deep. There was total hyphema and 4+ cells and pigments with complete aniridia. The patient was aphakic. Definitely we can see the translucent globular mass, the lens back complex, which spontaneously fell out as well as soon as we opened the eye. And this is the photograph showing the aniridia and the aphakia. So right eye scleral perforation with traumatic lens back complex extrusion, complete aniridia and complete ptosis. It was managed by scleral perforation repair under general anesthesia with GVP done within 6 hours of the presentation. 12 to 13 millimeter concentric nasal limbal laceration was noted. No vitreous loss was noted. The AC wash was done. The scleral wound was closed. So this is the 11 millimeter nasal scleral laceration, which was sutured. The conjunctiva was closed with 680 vehicle, and the AC wash was done, and the air bubble was retained. So post-operatively, antibiotic steroid and atropine was given. Recovery was uneventful. Intraocular ophthalmoscopy revealed hazy media, which gradually improved. Yes, sir. And he was observed. At last follow-up at 2 months, the BCVA improved to 624 with aphakic correction. There was slight improvement in ptosis, and unfortunately, it was lost to follow-up in the first wave of the COVID pandemic. So myriad consequences can be there, and the limbal laceration can be explained by Art's theory, wherein the sclera undergoes greater stretching at the point opposite to the impact and ruptures at the summit of this stretching. So in the exhaustive literature search, no report was found in which the lens back complex was extruded with complete aniridia and complete ptosis together. Phacoceal and pseudophacoceal, of course, have been reported, but in our case, the lens back complex was lying on the ocular surface and fell up spontaneously. So this happening in a previously normal eye is a rarely encountered scenario, and fortunately, this patient recovered good vision due to early intervention and identification of the problem. Thank you so much.
Thank you, Dr. Paul, for your presentation.
Please do come this side, Dr. Indrajit.
A very good morning. A very good morning, and thank you everyone for including me in this topic.
Yeah, please stick to typing.
Yes.
We have already finished.
So I'd like to present a case of a traumatic injury from a firecracker. So a 42-year-old male presented with PL vision. So if you have a look at the photo over here, you can see that there's a traumatic cataract with anterior capsular rupture and foreign body in the anterior chamber. So I'll quickly skip to the surgery. After systemic stabilization and ocular stabilization, we took up the patient. So this is me injecting visco, and that is the corneal perforation that is coming out. So we immediately went and sutured the corneal perforation. So I'll skip that portion because of lack of time. Then we aspirate the lens matter, and with a microrhexis forceps, we try to remove the foreign body from the anterior chamber. So this is a 23 gauge forceps. So this is the foreign body that was in the anterior chamber, and you can see vitreous attached to it. So then we go in for an anterior vitrectomy. Now the eye seems stable. And then we take a look inside. We had done a B scan prior to the surgery, so we knew that the retina is attached, but for any other eventualities. So we complete the anterior vitrectomy, and just a minute. Yeah, so we complete the anterior vitrectomy, and everything looks stable. So over here we took a call to defer the implantation of the secondary IOL to a second surgery. So this is the video of the second surgery. This was done 1 month after the first surgery. So one advantage was that the rhexis margin had already 5 more, so that provided us a proper support to put the secondary IOL, and we did not have to go for an SFIL. So once we saw that we had an intact rhexis margin, we went in for a simple scleral tunnel, and a single piece PMMA lens was dialed into the bag. So because this was a community patient, the patient was not affordable for anything more than that. And once dialed into the bag, everything looked fine for us over here. We checked the margin, the wounds were sutured and closed, and so this is 1 week post-operatively. The patient was seeing 660, and this is around 3 weeks post-operatively. The sutures are still there, but now the patient is seeing 624 parts, and we'll be calling him again after another 3 months and again correcting his visual acuity. Thank you.
Thank you, Anujit. That was a beautiful presentation, video presentation of Dr. Paul. And for the sake of the audience, I may tell you that it is one of the leading glaucoma specialists of our country, and he was there in one of the instruction course of glaucoma yesterday.
No.
Please start.
Good morning, respected teachers and sirs. I'm going to present a case series on management of squamous cell carcinoma of conjunctiva treated with radiation therapy. Squamous cell carcinoma of conjunctiva is relatively rare but potentially very aggressive malignancy of the ocular surface. Main treatment modalities include the surgical excision of the tumor followed by cryotherapy or topical chemotherapy or radiation therapy. My first case was a 65-year-old male patient with a recurrent progressive fleshy mass lesion in the bulbar conjunctiva of the left eye, which is recurring towards the cornea. Patient also complaining a diminution of vision, and patient has underwent corneal scraping with local anesthesia. Post-operative biopsy confirmed that it is a case of squamous cell carcinoma. So patient was treated with 6000 centigrade on the 10 fractions for a period of 2 weeks by isotope strontium-19. 3-year follow-up shows that there is no local recurrence. My second case is a 75-year-old female with a nodular lesion involved in the limbal conjunctiva of the left eye. She also underwent the surgery on the local anesthesia. Post-operative histopathology exams revealed that it's a squamous cell carcinoma, and the patient underwent beta radiation therapy with strontium-90, which shows 8000 centigrade over a period of 2 years.
Please sum up.
Sir, my conclusion is radiation therapy emerges as a well-tolerated modality of squamous cell carcinoma conjunctiva, providing a satisfactory local control where the ocular function needs to be preserved. So.
Great. Thank you.
Thank you, doctor. It was the last presentation, but not the least one. Good one. And over to Dr. Tariq.
And now I invite our past president of ACOIN, Dr. Tariq Qureshi, for his comments.
Good morning, respected chairman, co-chairman, and faculty members. I'll be talking about role of vitrectomy in ocular trauma. The role of vitrectomy in ocular trauma is immense, whether it's perforating injury or penetrating injury. Can you start the video? So, in penetrating injuries as well as penetrating, if at all there is an injury and it's not meticulously managed and there is vitreous in the wound, it can act both as a vitreous wick and vitreous tract, which resulting in epithelial down growth, fibrous ingrowth, and endophthalmites. And in penetrating injuries, it's very important to reach the posterior pole to manage it, to seal the perforation, and to tackle the associated detachment. Then the role of vitrectomy is in long-standing traumatic vitreous hemorrhages which are not resolved spontaneously over 3 to 6 months. Then the role of foreign body, if at all there is foreign body impacted in the posterior segment, it's essential to do a vitrectomy and remove the foreign body. Then foreign body associated with the retinal detachment is the treatment of choice is only vitrectomy. I don't know why video is not coming. Anyway, and there are situations where the foreign body is impacted within the posterior scleral wound, and as such there's only way of removing those wounds and suturing the wounds by vitrectomy only. Can John's
I think
okay, let's do without a video. Okay.
Thank you very much.
So I'll invite Dr. Sapanda.
Dr. Parag Mukherjee for your comments. Quick.
Only 1 minute. नहीं छोड़ दे मैडम leave it.
Your concluding remarks.
Unfortunately, I was very much late to attend due to traffic jam, so I couldn't get the all of full session. But whatever I have listened in the last 3 lectures are excellent, and attendance is very nice. Thank you.
Thank you. And then Dr. Samant.
Dr. Swapan Dafar.
Yes, 1 minute.
Just a minute.
Just 1 minute. Please stay.
Dr. Sanjana Chakraborty, please 1 minute. Do you like to say 1 minute?
Yeah.
I'll not read my this.
Leave it. Ma'am, leave the presentation. Just. Ma'am, leave the presentation. Just.
दो तीन दे दो ठीक है
बताइए
A very good morning to all of you. Sorry for the late. The ocular trauma, as you all know, that I'm not going to discuss all those things. Problem and what the prophylactic and preventive management, what should be done. This is a burning issue actually. In we don't have a proper ocular trauma register. That is the main thing. Most of the studies, they are coming very sporadically from different parts of the country, from eastern, western, southern. One of the most important study I could see, that is the Arvind Eye Care study. In those study, there was they have done almost 6,000 patient. And all the studies have shown that road traffic, the male are the more commonest affiliate. The road traffic accident has caused because of the alcohol consumption, and younger patients are more commonly affected. That is a very important thing to be noted, because they are the future of the society.
Thank you, ma'am.
So, what we suggest is that the effort to be taken, what can be done to improve the scenario. The effort to tackle problem of this magnitude has been highly inadequate so far. The data available is also don't have a registry. This is I have taken from Dr. Ashok Grover in IGO. He had a review article. The first step needed is to proper data collection. That is important thing.
Chandana,
and the rehabilitation and all. I'm not going. Thank you. I think.
Thank you, ma'am. Thank you.
Thank you very much for this extraordinary session. On behalf of ACOIN, Association of Community Ophthalmologists of India, I like to pay our sincere regards to all the chairpersons, especially the senior most. Dr. Yasin sir is here, who is now the Vice President of West Bengal Ophthalmic Society, who is the Executive President of ACOIN West Bengal State Chapter, and one of the pioneering ACOINian of West Bengal and the great community ophthalmologists of this part of India. And also we like to congratulate Professor Nepalia sir, who is the President-elect, and nobody else than our dynamic Chairman of the Steering Committee, Professor BNR Subuddhi, past President Dr. B.N. Gupta, as well as Dr. Shekhar Sarkar, who is also a part of our ACOIN, this part, and Professor Indar Mohan Rustogi, as well as Dr. Parag Mukherjee. I like to pay our sincere thanks to each one of you. Two things I just like to remind you in 2 lines only. Ocular trauma is the chapter of discussion all over the year by ACOIN. During this particular academic year from October up to coming 30th September, we will discuss everywhere in India only on ocular trauma. We have got 23 meetings from today. Every weekend we will be in any part of India, ocular trauma. Please do join. And our design is very simple. There will be 3 lead talk along with some discussion by the senior people, and all the junior ACOINian will give only 3 minutes talk on case presentation or a small study group design. And last talk, each ACOINian must prepare another ACOINian in this particular meeting. Please try to enroll at least 1 new member to ACOIN. Our ACOIN office is here. No more today. Thank you very much. We will again. Tomorrow we have got the extended managing committee meeting. Please come. All the speakers, please do come. We will have a group photo. Tomorrow at 8:30 a.m. boardroom, June Hotel. Extended managing committee meeting of ACOIN, and also send your nomination for ACOIN hours. এই সামনে आओ এই इंदर सामने आओ इंदर सामने आओ
वेट सर
Yes.
आप लोग का सर ये हो गया आप लोग पीछे आ जाइए थोड़ा मैडम थोड़ा पीछे आइएगा मैडम
अभी ऑफिशियल फोटोग्राफ ले लो
पीछे आएंगे पीछे जाएंगे
ऑफिशियल फोटोग्राफ
मैडम थोड़ा पीछे आइएगा मैडम थैंक यू मैडम कहीं सामने क्या बनना
थैंक यू सर आपका वीडियो नहीं चला चलो थैंक यू